Hello, and welcome to the Health System Strategies that Prioritize Children with Health Complexity webinar. My name is Colleen Ruland, and I am the Director of the Oregon Pediatric Improvement Partnership. I will be presenting and moderating today's discussion. Joining me today is Lydia Chang, a pediatrician and the Medical Director of the Oregon Pediatric Improvement Partnership. We are recording this webinar and it will be available on the Lucille Packard Foundation for Children's Health website in the coming weeks. We are also offering live captioning for this webinar. You can access the captions by selecting the closed captioning button at the bottom of your Zoom screen or clicking the link in the chat to view captions. If you are having any technical issues, please enter them into the Q&A and we will try to assist you. Questions. We are intentionally giving a very high-level overview of the information that is covered in the health system strategies to ensure a focus on children with health complexity summary brief. And we did that because we hope that we can prioritize time to hear from you about questions that you have and to be able to answer them. We will do our best to answer them at the end of the section. Lydia and I have agreed to stay a little bit later if we don't get through them all. And then if there are too many, we'll make sure to provide a written summary to the questions. All right, here is our agenda for the day. So first, we're going to set the context about our organization, the Oregon Pediatric Improvement Partnership, the grant funding that supported this work, and why it is important and integral as part of health equity efforts for health systems to identify and then implement strategies that focus on children with health complexity. Then we will review the recommendations that were provided in the brief that I hope you all read beforehand. And then we are fortunate to hear from 3 different health system leaders that OPIP provided technical assistance to in their reflections, some successes that they've had, and their input to those of you that may be starting on this journey. And then we will end with a question and answer session. So first, who is our organization that Lydia and I are fortunate enough to work with? The Oregon Pediatric Improvement Partnership is one of many improvement partnerships that exist across the country. Our mission is to support meaningful and long-term collaboration of stakeholders invested in child health care quality with a common purpose of improving the health of all children and youth in Oregon. We are primarily grant and contract funded and fortunate enough to be based in the pediatrics department at Oregon Health and Sciences University. The summary brief that you read beforehand and that we are covering in this webinar was made possible through a grant from the Lucille Packard Foundation for Children's Health that we are incredibly grateful for. This grant helped to provide support to OPIP to provide technical assistance to health systems nationally. You'll hear from 3 today. To the Oregon Health Authority, our Medicaid and CHIP program here in Oregon, and then to the contracted coordinated care organizations in our state that serve a majority of publicly insured children. You can learn more about that grant and a number of the products that were developed through that grant if you go to the OPIP website. So let's first start with this concept of health complexity and why is it that health systems should focus on children with health complexity?
Sorry, Colleen. So, we talked about health complexity and what that means, but I wanted to show this real simple and high-level representation of the concept of health complexity. When we first developed this framework, our visual actually included paint cans with blue paint representing medical complexity, so medical conditions that can significantly impact health and development, and yellow paint representing social complexity or social factors that could potentially impact health, with the mixing of those paint colors to make health complexity shown in green. We've since then evolved to talking about these concepts as puzzle pieces, with the blue and yellow pieces being just part of the picture of each patient, and the combination we now call health complexity representing the interplay of medical and social factors that can impact a child's health and their needs. We'll share a little later how these components can be operationalized, but throughout this work, this color coding that you're seeing has been intentionally aligned with these puzzle pieces.
So you all joined because the title of the webinar was Why Health Systems Should Focus and Invest on Children with Health Complexity. So why should you? The first is that children are an incredibly important population that health systems serve, particularly Medicaid CHIP agencies. They're often the largest population in terms of an age demographic that is covered by Medicaid and CHIP. Secondly, a key role that health systems play is population management and ensuring quality of care. And in order to do that, you need to be able to focus on the population and make sure that you're anchoring your population needs to measurement that guides that. So you can't focus on and ensure quality for a population of children with health complexity if you can't identify them. And later on, we're going to talk about the importance of collective impact models and community-based models. And so the value of having standardized language to define what it means for children to have health complexity and definitions for that population really can be helpful in terms of galvanizing and stimulating a cross-sector conversation. But probably most importantly, in terms of why we should be focusing on these children, is the importance of how health is really established and starts in childhood. We know that lifelong health and well-being often starts in early childhood. The indicators that we're going to present and the strategies that we are going to present are associated with costs and associated with poorer health outcomes. And we know that child health and development is particularly impacted by social determinants of health and equity. And so the value of incorporating indicators that relate to those helps to strategize and develop momentum for action to focus on those efforts. And then lastly, you'll see that a lot of the indicators we're presenting include factors that are based on the parent or caregiver. And as a health system, one interesting strategy for you to consider is that parent or caregiver not only impacts that child's health and well-being, but they're often also within your system.
So as a pediatrician, I've always had the strong bias that we must focus on children and do everything we can to set them up for success. And as crucial discussions about addressing health disparities and health equities have come to the forefront, I feel even more urgency in raising our voices that we must address inequities experienced early in life because they impact and predict future health and have multi-generational effects. To achieve health equity, we have to focus on children and their needs because intervening early can actually change their trajectory. So this is why this work has been so near and dear to my heart. Identifying and supporting children with health complexity, so those with physical disabilities, complex conditions, social challenges, systemic racism, historical inequities, or a combination of all of these, directly aligns with efforts to eliminate health disparities by focusing on the most vulnerable. This focus allows us to identify families who are likely to face significant barriers to care, to fast track these families into programs and services to address their needs before they lead to increased complexity, and to build dyadic or family-based behavioral health models that support intergenerational healing.
So let's start with providing a high-level overview of the information you likely read in the brief. So if you're going to focus on children with health complexity, your first priority step is to identify them. And so in the brief, we talk about the importance of identifying children using data available at the child level so that you can then aggregate it and summarize that data to look at the group level or the population. So what we're going to describe is how you may use data at the child level that identifies children with medical, the blue piece of the puddle, and social complexity in order to create a composite variable around health complexity at the child level that summarizes both the medical and social complexity. So let's dive into a high-level summary of each of those pieces of the puzzle, the blue and the yellow, in order to create the green.
So I'm going to go through those pieces with you all a little bit. For medical complexity, we use the Pediatric Medical Complexity Algorithm, or PMCA, which assigns kids into one of three categories: complex with chronic conditions, non-complex chronic conditions, and healthy. This algorithm was developed by a team at Seattle Children's and validated by the Center of Excellence on Quality of Care Measures for Children with Complex Needs. The algorithm uses claims data from health system databases and looks at utilization of services, diagnoses, and number of body systems affected to place kids into the three categories, capturing codes that are specific for children. What the PMCA shows us is that children are actually more medically complex than they look with adult-centric algorithms that are generally used for rate setting and risk stratification. And we'll provide some examples of the implementation of PMCA a little bit later. Now, defining social complexity is inherently challenging. We based our social complexity component on the definition provided by the Center of Excellence on Quality of Care Measures. which is here, a set of co-occurring individual, family, or community characteristics that can have a direct impact on health outcomes or an indirect impact by affecting a child's access to care and or a family's ability to engage in recommended treatments. A list of social indicators were identified and validated by the Center of Excellence and have been shown in the literature to be predictive of a high-cost healthcare event or to be associated with poor health outcomes. As you'll see on the next slide, many of these are also aligned with adverse childhood experiences and have been shown to impact the ability to access and follow through with care. So as you look through this list of 18 social indicators, they're likely not surprising. We know many of these factors impact reliable access to primary care home, stable housing, food and transportation, education and job security, and all of that can impact health and how people utilize the healthcare system. For children, the impacts can last into adulthood and lead to increased medical and social complexity as they get older.
So once you have the medical at a child level indicators and the social complexity at a child level, then you can do the innovative work of combining those variables to create a health complexity indicator. The reason this is important is we know that what you might do for a child who's medically complex and socially complex is going to be very different than what you might do for a child who has social complexity that if we don't intervene early might lead to medical complexity. In the brief, we spotlight an example from Oregon of a 9-part health complexity variable or index that summarizes both the medical and complexity of a child. So what you'll see is these 9 cells represent the 9 different indicators that were created in Oregon. On the left, in terms of the rows, those are the 3 categories of the pediatric medical complexity, with the first row being children with the highest level of medical complexity, the second row being children with non-complex chronic conditions, and the third row being children with no medical complexity according to claims data. In terms of the columns and creating the 3 columns, in Oregon, we identified 12 social complexity indicators that were aligned with the definition that Lydia just shared and that aligned with the specific indicators associated with poor health outcomes and cost. And we created a category of those 12 variables that summarize them as 3 or more, that first column, 1 to 2, the second column, and none according to what's in the system level data. And so that's how we created the 9-part variable. The value of what this shows you, it helps you be able to identify children that have health complexity, so the shaded in green, meaning they have both medical and social complexity. So if you look here at Oregon's data, in terms of children enrolled in Medicaid and CHIP, you'll see that 25% of children, if we add up those 4 green columns, have both medical and social complexity, where only 3% of children in Medicaid have just medical complexity. If you look at the bottom row, you'll see that 23.9% of children, that 123,764, are children that have 3 or more social complexity indicators, meaning that if we don't intervene and build health and resilience, the literature would show us that they're likely going to move up that column and develop medical complexity. So in the brief, we made sure to share innovation examples that have been identified across various settings through our technical assistance. And that's in terms of on page 5 of the brief, we summarized how other states have implemented this health complexity model. So you'll see that in Oregon, we've been implementing the child health complexity model since 2018. The way we've operationalized the PMCA is using that medical complexity, and the way we've operationalized the social complexity that I just shared is using the Oregon Integrated Client Data Warehouse. In the brief, there is a link that provides a summary to another brief that provides a lot of detailed descriptions around the methodology that was used in Oregon. And then we also will be sending, after this webinar, links to our website and to articles that provide more descriptive information if you're interested in learning about the Oregon experience. We're really fortunate today to have Elizabeth from Colorado, who's going to be sharing how she thought about incorporating components of the health complexity model in Colorado. In terms of operationalizing the medical complexity, they too use the pediatric medical complexity. And then in terms of operationalizing the social complexity, you'll see that they identified a number of factors associated with the definition for social complexity that Lydia shared and associated with health systems not working well for these populations. Lastly, in the brief, we summarize work that OPIP did with the Kaiser Permanente Northwest system, where they too implemented a model to yield a health complexity index. For the medical complexity, they too use the PMCA. And then for social complexity, they utilized data in the electronic health record and implemented new screening at well visits that aligned with the social health complexity indicators that Lydia shared. So that's that priority step. You first need to have child level data so that you can then think about how you might do strategies that ensure a focus and quality for these children with health complexity. So let's talk about the 4 option strategies that we described in the brief. So in the brief, we provided 4 different options. First, enhancing awareness, analysis, refinements, and use of data to galvanize, guide, and inform improvements in care. The second option was ensuring the needs of children with health complexity are met, kind of like the basics as a health system for making sure that those children you serve are getting their needs met. The third is assessing for quality for children with health complexity and how these health complexity indicators may be a useful strategy within that approach. And then the fourth is prioritizing investments that build health and resilience in family-based approaches. So let's go through a high-level summary of these 4 strategy options that are presented in the brief.
So we have the first option here. Once we have this child level health complexity data, one key strategy that could unlock its potential impact is to ensure that all those who support children with health complexity are aware of the data and understand what it represents. The data can be shared with providers, public health, and community partners, and this sharing actually serves several important purposes. Having leaders and communities understand the data can create opportunities to use the data to improve care. And this understanding of the data also allows partners to give input on refinements or creative analyses of the data to meet their individual priorities. Some potential analyses include stratifying the data into subpopulations to ensure a lens on specific groups of children, and include segmentation by age group, race and ethnicity, specific primary care practices children are attributed to, and specific regions. And finally, the data can be shared alongside the voices of families with lived experience, those who have children with health complexity. So everyone who sees and uses the data understands the individuals represented by it and recognizes the strengths and limitations of the data, as well as some of the real life barriers we're trying to address.
In the brief, we spotlighted a number of strategies that have been used here in Oregon. You can click on the brief to the Oregon Health Authority's website to see the data that is provided to each of the coordinated care organizations that have accepted risk in Oregon to serve children. We spotlight an example in Douglas County. A private funder, the Ford Family Foundation, supported a collective impact effort in Douglas County to galvanize action for children with health complexity. And I'm going to share a community-driven, community-informed call to action that was developed based on the data that was presented. And then lastly, in Marion County here in Oregon, the data was used by a collective impact effort called the Community Business and Education Leaders. And they analyzed the data by zip code in order to prioritize where they may make investments for housing. And then based on the social complexity findings, ensured that the housing included dyadic behavioral health support so that they could better meet the needs of the children and families that would be supported in those housing structures. So one of the links that we provided in the brief is to this call to action that was developed at the community level in Douglas County. And what you can see in the action brief is that the data was used to spotlight the need. We had parent voices there to strategize what the input they had in terms of the systems and how they could be improved. And then the community identified a number of priorities for collective impact work that were needed in order to address the gaps and needs identified by the data quantitatively and by parents qualitatively.
So the second option we highlighted is to use the data to ensure that the healthcare needs of children with varying levels of health complexity are being met. With the data, we can look at children with different levels of medical and social complexity and evaluate whether they are receiving routine recommended care. This could allow for targeted improvement efforts to address access to care for different groups. Having the data can also help prioritize children with health complexity for care coordination supports. Once health systems can identify a population of children with high health complexity, they can create family-centered strategies and provide tailored supports and cross-sector integration of care for them. Knowing the magnitude of children with health complexity can also help with investments in care coordination staffing models. So it provides a lot of information for us to better care for this population. And finally, the data can be used in conjunction with individual assessments of a family's strengths and priorities to tailor supports based on the degree of health complexity. So for example, the approach for families of children with complex chronic conditions and very high social complexity will likely be very different than the supports needed for children who have non-complex chronic conditions and one or two social indicators. So a targeted approach based on knowing an individual's health complexity and having a direct assessment of a family situation could significantly improve their care experience and help to allocate resources better. So Colleen's going to go through some examples of this option strategy as well.
So as a health system, you do a lot of different things to ensure that the basic needs of your children are met. You're probably examining well child care rates or immunizations. One really exciting applied use of this data is to actually look at the basics like immunizations and well child visits for children with medical and social complexity. The value of being able to illuminate the data for these subpopulations is it gives you a clue as to the root causes and root solutions that you can take to better support targeted outreach and family-centered strength-based approaches to ensure those children get those basic needs met. As Lydia mentioned, one of the values of this data is that you can also use it to target the investments and programs that you're doing to support care coordination. So for example, it may be really useful to look at those 25% of children that I just showed you that have medical complexity and social complexity. How many of them are receiving care coordination or wraparound services? And when you see a gap in those services, how might you target the services to address the root causes? So for example, care coordination for a child that has both medical and social complexity will need to look different than the kinds of care coordination that would exist for children that have just medical complexity. The third option is assessing for healthcare quality for children with healthcare complexity. And obviously this overlaps and integrates and relates a bit with the second option as well. So the first thing you can do is you can assess for quality of care for children that by their health complexity indicators. And you can use the health complexity indicators to create subpopulations. So subpopulation 1 could be children with medical complexity. Subpopulation 2 could be children with social complexity. Subpopulation 3 could be children with both the health complexity. It's really valuable to be able to look at the 9-part categories that we shared as an example in Oregon, and to examine your traditional quality of care metrics by those different populations. Again, because each one has a different answer to you in terms of the root cause solutions in order to better meet the needs of children. The second is then once you have populations that you can stratify and create subpopulations for, you can create incentives for those populations. So what would it look like to create incentives for children who have medical complexity to ensure that they have preventive services? What would it look like for children who have social complexity to create incentives around the behavioral health metrics that you used, for example? And then lastly, because the health complexity definition is aligned with a number of factors that are associated with health equity, the indicators can be used as a way to stratify and incentivize a focus on populations as part of your health equity efforts. In Oregon, this is particularly important because in Oregon, there is currently really high rates of data missing when we try to look at data by race and ethnicity. But the rates of data missing when we look at the health complexity data are much less. So this is a great strategy to kind of look at factors that actually impact health, lifelong health, and are associated with systemic racism in order to move that ball forward while we work on implementing strategies to enhance and improve the quality of data by race and ethnicity. So some examples that we shared is we know that Medicaid CHIP agencies are currently focused on reporting the child core set, which will go mandatory in terms of reporting. As states are reporting those metrics, there's this great opportunity to think about how you may stratify the metrics by children with health complexity in order to inform your gap analysis and in order to ensure that the efforts that are conducted as part of that work around the child core set include an equity focus. It's a really great way to make sure that targeted improvement efforts not only ensure breadth in terms of improving quality of care for the core set overall, but how do we ensure depth for the children that most need our systems to improve? Another set of metrics that you can use and stratify the data by that we highlight in the brief are metrics that are associated with cost. So for example, there are ways you can examine avoidable emergency department use by children with health complexity. One of the things we found in Oregon is that the rates of avoidable ED use in children with only social complexity were just as high, and in fact, in some regions higher, as children with medical complexity. Why is this important? When we think about the root cause of the avoidable ED, and we think about strategies to reduce the avoidable emergency room department, if we understand that one of the drivers is social complexity, then that's going to help health systems design better best match strategies to meet the needs of children. And then lastly, many of your health systems are looking at prolonged hospitalizations, so hospitalizations that last more than 30 days, or repeat hospitalizations. And again, we found that children with health complexity are more likely to have prolonged and repeat hospitalizations. And so these data can be a helpful guider of the kinds of improvements that'll be needed specific to the type of complexity that that child has. The last option that's presented in the brief is how you may use the data to prioritize investments that build health and resilience and incorporate a family-based approach to care, which is so important for children. So one of the strategies we listed was to develop payment models to incentivize and compensate for high quality care. One of the kind of phrases that OPIP uses in our work is that we know that is what's measured is what's focused on, and what's paid for is really focused on. And so how do you think about the value of these child level indicators in informing payment models? These could be models that are applied at the primary care level in terms of looking at the aggregate group population attributed to the primary care and determining rate setting processes that could actually cover the care coordination and other supports needed for children with health complexity. The data could be used to look at behavioral health and investments needed. When you look at those social complexity variables in alignment with adverse childhood events, we know that behavioral health is a really important solution. So examining population rates by what provision of services being provided and thinking about payment models that may support that gap is a really interesting strategy. When you look at the root causes, some of the solutions to the root causes will be supports like traditional health workers and community health workers. So how can you use the data to make a business case around supporting those kinds of services that really meet families' needs? And then lastly, when you look at that data, it's hard to not deny that there are an important group of children that actually need us to develop best match care coordination wraparound services. And so how can the data be used to not only understand what is the magnitude of children that likely need those services, but then how do we ensure that those services are provided in payment models that align? One of the really important parts of being able to have the child level data is that we found that many families have multiple children that have health complexity. So when you talk to a parent of a child of children who have health complexity, they ask you to take a family-based approach because that parent's managing that child's needs individually, but they're also managing their family needs. And so the value of having a child level indicator is that you can then roll it up at the family level. And then you can think about ways in which you might create a family-based model of care coordination that really takes into account the balancing act that families with multiple children are taking. The other value of having it at a child level and understanding that a number of these indicators are based on that parent or caregiver is that you might also think about approaches that take into account the dyad. So what would it look like to take into account what does that parent need in order to be successful in their health and the supports that is impacting that child? And so the value of the child level data is that you can potentially link to the adult that's also in your system and think about payment models that may support that dyadic care coordination and dyadic provision of care. So in the brief, we provided 3 different examples of ways in which you might use the data to really think about how to build health and resilience and models around health and resilience that really support a family-based approach to care. One of the first examples that we provided is here in Oregon. We currently have a focused effort on ensuring social emotional health services are provided to young children. The coordinated care organizations that accept risk to provide services to children are looking at their rates of social emotional services overall, but they're also looking at the rate for children by health complexity. So looking at children that have multiple adverse childhood experiences and how many of them received social emotional services, and then thinking about what would it look like to target social emotional services for those families who have experienced trauma and for which we might think intentionally about building health and resilience in that first 5 years of life. Another example that we provided is the value of looking at the data by primary care home. In Oregon, a number of children are attributed to primary care homes who then receive value-based payments. So how do we think through how that data could be used to inform those value-based payments and support the kinds of services that children with health complexity need? Another strategy is to examine the data by zip code and then to think about how you might use that data to invest in community-based care coordination supports, integrated behavioral health, or other supports. An example of this that we provided in the brief is in Central Oregon, the data was analyzed by zip code, and disparities in access and availability of behavioral health services was identified by zip code as compared to the prevalence of the need by zip code. And so this data was used to help inform building better behavioral health supports where those children with health complexity exist. So that's an overview of the 4 option strategies that we presented for how you might use the data. Again, in the issue brief, you see a lot of different examples. But what I want to do now is actually transition to hearing from people, health system leaders that OPIP provided technical assistance to as part of our grant funding from the Lucille Packard Foundation. I'm so incredibly excited to have 3 different health system leaders on our webinar today who are going to share a little bit about after receiving technical assistance, what did they learn? Where were places they were really excited about? What's some momentum they've been able to achieve? What are some barriers they've potentially experienced? And then recognizing that there are hundreds of people on this webinar today, as you may be starting on this journey, what areas of input do they have for you? So we are fortunate to have 3 health system leaders today. The first is Dr. Brina Holmes. The second is Elizabeth Baskett. And the third is Dr. Steve Karras. So what I'd like to do is actually, I'm going to stop the slide so that we can see our wonderful reactants. And I'm going to start first with you, Brina, in Vermont. I'm curious to hear your reflections. You've been able to see the kind of recommendations that we've had in Oregon. What are some of your reflections and what are some of the places that you're trying to move forward in Vermont?
Well, first of all, Colleen, thanks so much for having me. And as always, when you present this with Lydia, I learn something new every time. So I do think one reflection is just slowing down and the repetition of the sort of how we're using this incredible groundbreaking work, but then how we can continue to use it. So the Vermont reflection is we have a single state accountable care organization with great leaders, but they were in a very traditional space of using medical complexity for risk stratification for determining how to give resources to people who deliver healthcare. I mean, it was incredibly straightforward that if you had more medically complex patients in adult or pediatric care, you received more resource, human resource for care coordination, but also financial resource. And when they first did the stratification of risk for children in Vermont about medical complexity, it was a single-digit percentage point of children who would fall into the highest risk category for receiving the most support in primary care, which stopped us dead in our tracks because it just felt, again, those of us that work in pediatric space, here we go again, resources being allocated to adults with chronic disease when we need it in child health. And so it was just, we were so lucky and grateful that we knew Colleen through our National Improvement Partnership Network. And we had this inkling that there was something going on around social complexity and accessing what I call human service data, because I just left state government after 12 years to join the Vermont Child Health Improvement Program. So I can stop there as the first reflection. I don't know, Colleen, if you want everything in my brain or if you want to alternate reactants. So I'll go back on mute.
Okay, I'll pass to Elizabeth, and then if we have time, I'll pass back. We'll make sure we get through our questions, and then we can react to each other. Elizabeth, do you want to share a little bit about your journey in Colorado and some successes, some reflections, and input to others?
Sure. We had a similar experience to Brina, where our Medicaid agency was highly focused on medical complexity, but not even on children, more so on adults, and almost trying to apply their methodology and thinking to children, which we all know here does not work. And so we were able to work with the agency to think more about, from the child perspective, the medical complexity, but also introduce the social complexity. And so we were so thankful for you, Colleen, and the work that you've done to be able to share, bring the data is one of my recommendations to the group, to the agency, to show the research of how social determinants of health impact the child and the family. And with that work, sharing that information, the model as well as the data with our state agency, we were able to get them to move towards a child risk stratification and to look at data that they already had at their fingertips. So data on ethnicity and race, citizenship, and limited English proficiency is where we started. And I'm happy to report since then, the state has started to reach out beyond its four walls of the agency, talk to other agencies to try and pull other social health information. And even outside of the state agency level, they're now building a social health information exchange and working to build some infrastructure so that hopefully this data can be used within the Medicaid agency by our accountable care organizations, but also to be used by community partners like you've been able to do in Oregon and by providers. So we've made some progress. There's still so much work to do, but being able to have this health complexity model and bring it to the department with the data and the impact in Oregon was really pivotal in our efforts to get the agency to think about children and how to approach them from a Medicaid perspective.
Thank you so much, Elizabeth. It's so hard for me to have you and Brina only share for 5 minutes, but I want to make sure each one of you share, and then hopefully we can collaboratively answer some of the questions I'm seeing. Steve, I'd love to hear from you about your experience in New Jersey and what you all are learning and some opportunities and input you have for other health systems as they start their journey. And I think you're on mute, Steve.
Yeah, thank you, Colleen. And just like Brina, I wanted to say, I always learn something when I listen to Colleen. And what I learned today was I want to move to Oregon. So, but getting to New Jersey. So we're being involved. We're one of 7 states involved with the CMMI Integrated Care for Kids project, which if you don't know what that is, and hopefully many do, but it's really a transformative approach by Medicaid to try to be both population-based and be able to identify and provide additional services for kids with complex needs, with the definition being medical, behavioral, and social, just as Colleen and Lydia were describing in Oregon. So we've been on this journey now for about 3 years. New Jersey was a state pretty much mired in the 1950s in terms of being a fee-for-service state, not really based on population health or value-based payments. So as you can expect, there's been a lot of barriers along the way. We developed a very comprehensive needs assessment to include the social determinants. We decided to do it as an app so we would not overwhelm physician offices with the screening process and just have them see the results and actually get paid for the results. There's an alternative payment model for Medicaid to pay for the community-based services, community health workers, family support people, social workers. They're really a very, very transformative process in a state that is not used to getting involved in these fields. So I would say, it's been very exciting, an exciting journey. We still have 4 more years to try to see how this is all going to work. We're still in the early phases of spreading this to 2 counties, 145,000 kids who receive Medicaid in those 2 counties. I think are some of the barriers is that for this to work, state government has to be really invested in it. So far, it's been somewhat of a passive aggressive interaction with the state systems. They support it, but then but not really. And again, certainly COVID, et cetera, has put a damper on their engagement. The other thing is that for this to work, I think the patient-centered medical home providers have to be not just understand what it is, but fully incorporate it and change the way that they provide care to incorporate the community-based aspects, the social determinant work, the more global population-based approach. And it's the old statement that every system is ideally organized to get what it gets. That's pretty much what you see in a fee-for-service state. So making that move has been slow at best, but we're making progress, and we're still optimistic. So thanks, Colleen.
Well, I think the strategy, when I look through some of the questions already identified, I think what I'm going to do is actually pivot to some of the questions, but then I know some ways that you, Brina, Steve, or Elizabeth could help illuminate a bit more some of the questions. So one of the questions that I see on the first question that I see is, can you talk about the difference between the pediatric medical complexity algorithm versus predictive modeling programs like Johns Hopkins? And I'll add into it because I see other questions that are about payment. And so what I'm going to do is I'm going to pull up a slide that Lydia actually covered and just go through it a little bit slower. Is this, Lydia, is this the right setting now that I'm resharing? It is. Okay. So one thing is the pediatric medical complexity, almost all systems, I think in terms of like the input in this brief, is pretty much anybody that has administrative claims data can run the pediatric medical complexity algorithm. And I would highly recommend that those of you who are advocating to health systems or those of you that are in health systems do so. A lot of health systems and Medicaid agencies, when they're determining their rates and determining the level of medical complexity, use something called the chronic disability and payment system. And the reason that it was developed at Seattle Children's, the pediatric medical complexity algorithm, was actually to identify the blind spots in the chronic disability and payment system in identifying children with medical complexity. And so I think that's part of the reason we have underinvestments in children, is because we are using a model to establish rates that does not identify their medical complexity. And so if you actually just do a literature review on pediatric medical complexity algorithm, the Seattle Children's Group has published a lot of great research around how they developed the pediatric medical complexity and why they developed it the way that they did. But the basic question was, can you tell us a little bit more about the categories in the pediatric medical complexity algorithm? So the first category is children with complex chronic conditions. And so an easy way to think through how those algorithms define the definition between complex versus non-complex is that in order for a child to go into the complex chronic conditions, the algorithm takes into account that multiple body systems have to be impacted in order for that child to be categorized into PMCA1. So Lydia gave a great example in her slide of a child with cystic fibrosis, for example, is a child that would fall into complex chronic conditions because of those multiple body systems impacted. The non-complex chronic are children who have, more easier chronic conditions in terms of not multiple body systems impacted. So the example given was asthma. What we all know is that a child with asthma who lives in a highly socially complex environment can actually be extremely high cost because that social complexity impacts their ability to access care and impacts their ability to follow through care. And so that's why that kind of added element of social complexity on top of medical complexity was so important. So the basics of the pediatric medical complexity algorithm is that it looks at administrative claims data, and then it looks at the services that are utilized, it looks at the diagnoses that are utilized, and then it looks at the number of body systems impacted. And then based on that algorithm, categorizes children into one of those three categories. Lydia, is there anything else you want to share before I go to the next question?
I think just that a lot of the traditional algorithms are very adult focused in the diagnoses that kind of will trigger their algorithm to run. And so the PMCA does include, and they've updated it many times, include a lot of pediatric specific conditions, given that kids don't have like the top 5 adult conditions like heart disease and diabetes, but have a lot of different conditions that could fall into, you know, sort of their medical complexity. And so I think that's one of the things that really adds to the value of the PMCA.
Well, and Colleen, I could see from the questions too that, and as Steve and I said, and probably Elizabeth feels too, you have to hear this several times to get it into what you know and what this is new and what you're learning. That's all medical complexity, and I'm glad we're talking about it. Then there's a lot of specificity that comes with talking just about children. But the innovation here is you have to have friends in state government that will allow access to social complexity data in order to do this analysis that brings you to the true health complexity of the children in your state. And that those friendships, Steve said something sort of funny about, I think you said passive aggressive, that you really have to cultivate, and Colleen can help. That's what I wanted to say if I was back on when the Vermont team heard from Colleen, it opened up their brain that, you know, parental incarceration data, just as an example, could be released to health systems to think about the children that we serve. So it's a really interesting, you know, there's a lot of concern and fear about privacy and who gets what data. And Colleen and Lydia have worked out beautifully the parent voice in this and the representation and how much people want this type of sharing to actually get a real picture of the experience of being a family in a state. Okay, I'll go back on mute.
I just wanted to add that, you know, in addition to traditional medical and social, I think the behavioral aspect is critically important. That's a part of all this. And I also wanted to, again, it's probably not new to anybody, but this is a 2-generational business. We're not just talking about the child. Clearly, the family matters a lot. And, you know, looking at parental health is a tremendous indicator about how well they're going to be able to manage and how well the children are doing with their complexity.
One thing I have to say to this power of like getting people in a shared room to work together, and like, how do you get people to be nice and start to talk nicely, is usually the silos are caring deeply about the silo that they focus on. And so when you bring together multi-system data, that one, you show the data and they see their services represented there. But then 2, when you pair that with parent voices there at the meeting, it's hard to look at the magnitude and it's hard to hear the story and walk away. And so that's why in our option 4, we really talked about that power of pulling that shared table, and then having the quantitative data, because it's hard to deny it, and then the qualitative data of that parent voice there, because I've just noticed a shift in a room when that happens. Chris, I saw that you said, whoa, that rate of medical complexity is higher than we've seen. I want to just like address your comment in terms of methodology for folks. And then note, I actually do think it's a lot higher than people think. And so I think this is on us to better articulate for children, because most children think children are healthy. Most people think children are healthy, and that is why we have the systems that we have. So Chris, we use the all payer, all claims database, which means that for children in Medicaid CHIP, if they had a secondary, if Medicaid CHIP was a secondary insurance, we were only capturing their secondary claims. And a lot of children, the reason they're eligible in Oregon for Medicaid CHIP is because of their special health care needs. So originally, our rates, though, were still about 19%, with about 7% in that complex chronic. But when we added in the all payer, all claims, the rates went up to 30% because we were actually capturing all the services that children receive. And I think states that have a much more restrictive eligibility criteria than we do here in Oregon will find that their rates will be high. So you are correct that we are finding about 30% of children, when you look at medical claims, so those are the kids who are able to access healthcare and able to access services, had a medical complexity, and about 10 to 11% were complex chronic. Our partners in Vermont have found very similar rates, and Steve in New Jersey has actually found similar rates. So I do think there's this opportunity to raise awareness around like actually the proportion of children with medical complexity when we look at claims within the system. Because again, then when we think about, well, what are our systems doing to be perfectly designed to serve these children? I think that's an important part. We had another question about like, can you again describe how you developed or defined medical or health complexity? So again, health complexity is the green. So I'm just going to use this table to describe it. So health complexity means kids that have both. And so Lydia described the medical complexity using the pediatric medical complexity algorithm. The yellow is looking at that definition of social complexity. And then here in Oregon, for example, we used a database that captures very different data sources that you can look at. And then health complexity is combining those two variables into creating a similar, into creating an index that describes both of them. So in this table that you're seeing, the health complexity indicator, that 5.1% that you see, and the 3.7% and the 9.2% and the 7%, the reason it's shaded in green is those are kids who we would say are health complex. And the reason is because they have both the blue on the left, the medical complexity, and they also have one or more of the social complexity indicators. So for example, that 5.1, the 26,650 kids in Oregon, they're highly medically complex, so multiple body systems impacted, and they have 3 or more social complexity indicators that are associated with poor health outcomes. Okay. There are some questions around, I'm going to stop share now so that it's not as distracting. There are some questions around how do you get people to look at children with complex medical complexity when the vast bulk of their costs are in adults with complex needs? I think the first one is particularly around quality requirements, is to actually stratify the quality requirements around that, because there are basics around quality reporting. And so I think that's the one of the first places you can start. I'm actually really interested, as a person who's only focused on children for my 24 years of my career, about like, great, let's play this adult game. Because the interesting part is in Oregon, we've actually looked at the children that have the most medically and socially complex needs in Medicaid and CHIP. In those kids who have things like parental incarceration, parental substance use, parental mental health, 3 factors highly associated with higher healthcare costs and extremely predictive of child welfare involvement, that adult was also on the same health system. So one of the strategies we've been thinking about is, how do we actually say, yes, systems, you do need to focus on adults. You are currently rationing your supports and systems for adults. What we're asking you to do is ration your supports and systems for adults with children, because you might actually have a return on investment that if you actually think about that dyad, you might create better systems that'll support that adult because you're thinking about their North Star, and create the kinds of supports and care coordination that address both what's happening for that adult and that are then impacting that child. So I think it's a way that we can start to get health systems to focus on children by actually connecting them to their adults and saying, we too agree you need a family and dyadic-based approach. Do any of my co-commenters want to comment on that question? Because it's a loaded question and one that I think is important.
I do think one thing that we talked to Brina about quite a bit is in Vermont, there's a big focus on identifying vulnerable individuals. And sometimes they're not utilizing the system and we're trying to figure out who they are. And so in a lot of ways, we felt that by identifying children that may be complex, we may be actually capturing some of the parents, the adults who aren't necessarily taking care of themselves potentially because of a lot of different social challenges and they're focused on their children. And being able to identify them is actually a benefit of knowing which kids are complex.
And I would just add in Colorado, we continually face the challenge of a focus only on high cost patients. But because there are quality expectations on the federal level, and there are advocates, and there are some people who see the long-term impact of kids not being taken care of, we do get some focus on children. And one of the things we were able to get our Medicaid agency to do is to start to work on tying the parent to the child in their system, in their data system. And that is much, much harder than you would imagine. And so just getting to that step has been huge for us. We call it 2Gen in our state, 2 generation, looking at the whole family. And your point, Colleen, is a good one, that if the child is unhealthy because of these different risk factors, the parent likely is as well. So why not treat the entire family? We've got a care coordination model where our care coordinators go to people's homes. So it just makes sense to serve the entire family. And it would be so nice to see our Medicaid system move more in that direction.
And I would add that I think the wheels are a little bit greased in this direction with the work of Felitti, et cetera, on the huge impact of trauma on adult health. So that I think really for the first time in many states, people are recognizing that money put into earlier solutions would save a lot of downstream pain and costs.
And I'll just add that because this system change is so significant and we're going to need to talk about it over and over again, there are actually adult data sets that exist that we don't know if that impacts children. And so what Colleen's and Oregon's been able to do actually has been driving some change in Vermont about parental incarceration. Sometimes when someone's incarcerated, we don't know if they're parenting. So it's a meta thing that's really been powerful. Also in some of our substance use treatment work and mental health treatment for adults, we weren't actually checking boxes or even checking in if there were children involved. So we can go many levels on the impact of this work, but that's important as well.
I'm going to take one more question during the regular time. I'm going to show where people can go to access information. Everyone that registered is going to get a follow-up email. But then Lydia and I are happy to stay. I won't coerce my co-presenters, but if you want to stay, you can, because I think there's maybe 6 questions I won't get to. So if you can stay, we're happy to stay to answer them, but I want to make sure for other people we stay on time. There are a couple questions about this idea of like, how do you use the data at the primary care level in terms of patient-centered primary care homes? And somebody asked a question like, can you give me examples of like, what would it actually look like to do value-based payment in patient-centered primary care homes to improve tiering and special attention? Well, one is right now, as I'm aware in our state and in working, I'm on the Primary Care Payment Reform Collaborative, which is a legislative committee in our state. Currently, there is great work happening in our state around payment models that support PMPMs for primary care homes who are patient-centered medical homes. And those PMPMs are higher based on the tier level of medical home. But they don't take into account at all the patient demographic of who that practice serves. So we've done analysis that have shown, we worked with a practice who 40% of their children had medical complexity, 1/3 of their children had social complexity that was parental incarceration, parental substance use, parental mental health. So when you think about what would it take for that patient-centered medical home to do a tier 5 service if 40% have medical complexity and if 30% are highly socially complex, what it would take is multiple care coordinators, and what it would take is integrated behavioral health. And if there's one rate that's established across all patient-centered medical homes, that's like everybody gets a $1 PMPM based on your tier, then we're not incentivizing patient-centered medical home for the very population that it was developed for. So one way is to actually adjust your payment rates, your PMPMs, not only based on tier, but also based on the demographic characteristics. So to increase, for example, the behavioral health PMPM for a practice whose population is highly socially complex. And that kind of addresses some of the other comments about, like, if we only use medically complex, we actually disincentivize those systems that see highly socially complex families. And I agree. And so I think this is a really neat way. And it's why you have to have data at the system level, because you can't do payment reform unless you have data for that full population. Another way, and it's the last example I will share just to make us stay on time, is every value-based payment methodology I see has quality metrics that are tied to it. You have to meet this metric in order to get this value-based payment. I've never seen those rates be anchored to certain populations. So what would it look like to say, you have to meet this well-child visit rate, this core measure for children with health complexity? So not the full population, but actually, how do you create an incentive for them to focus on equity first? Or how do you create an enhanced bonus if they achieve the overall rate, plus they receive that rate for children that are socially complex? That's how we'll start to turn the gears to support the kind of payment methodologies that are needed in order for patient-centered medical homes to actually have the resources that are in place. So you will be receiving the slides in an email from the Lucille Packard, but if you want more information about this work, you can find a bunch of resources on the Oregon Pediatric Improvement Partnership website. Lydia and I are more than welcome. We are more than happy to answer any emails that you send us with questions. We'd love to help any and all children. We have a very vested interest in children. And so any way that we can support systems across the country focusing on children, we'll do our best to support. I really want to thank Brina, Elizabeth, and Steve for joining, and thank all of you for attending. And then again, we'll stay on for those of you that answered questions, if you can stay on in order to answer them. Apologies that we didn't fully get to them, but thank you so much for your time, and thank you so much, the Lucille Packard Foundation, for your incredible support.